Perfect, perfect. Hello, everybody. Welcome. It is Tuesday night, and we are here with, hold on, we got people coming in the room. All right, let me turn it off over here so you guys can see one screen. Let me start over. Welcome, everybody. This Tuesday night, we are here with the incredible Dr. Eric Armican. Thank you so much for being with us tonight. Dr. Eric Armican is a board certified diplomate of the American Board of Pediatric Dentistry and laser certified professional, experienced in the release of tethered oral tissues. Since becoming a pediatric dentist, he has continued to educate himself to provide the best for his patients. Not only has he gained a wealth of experience as a release provider, but he has continued to learn about all aspects of the team, the area that are needed to provide the best outcome for his patients. He values a conservative and collaborative team approach for optimal health. He treats patients all over the DC area, Maryland, and Virginia area. Thank you for being here. Would you like to say hello to Airway Circle?
Yeah, thanks for having me. I've been a fan, obviously, and kind of watching some of the other speakers and all your stuff, and so I feel really excited and fortunate to be here. And I see some familiar colleagues that are logged in, which is really cool to get to share this knowledge kind of all over the place instead of just at a course in one local place. So this is awesome.
This is great. Well, guys, if you have any questions for Dr. Eric, please just post on the chat box or on the comments, or you guys can ask Angela if you are on Clubhouse. So I'm going to be sharing the screen. I'm not sure if you guys can see. Is it better now?
Perfect.
All right, just let me know to keep scrolling. I'm going to turn this off. Can you guys see anything else besides what you're supposed to see? We're good? Okay, I'm going to mute myself. And the stage is yours.
Cool. Well, and thank you so much for the intro. My little presentation I'm going to kind of do for you guys is you don't know what you don't know, and just kind of giving the perspective of a pediatric dentist and why we can be a valuable asset as a release provider, and what this kind of space means to us and how we can be a part of this team. So that's one of my kids there that you see with the rain boots on a really warm day, but you'll get to know them a little bit. So
is she related to my daughter?
She's oh, you have one like that too, right? It sounds like
my daughter only wears rain boots everywhere.
Yeah.
So funny. I love it.
So some things we're going to talk about: who I am, where I came from, kind of how I got into this space, how I started, and what you as a potential release provider can do to start, or even other kind of role players in this process. How to grow and network, and these are kind of all hurdles that I had to try to figure out and climb myself while getting into this space. Again, why a pediatric dentist? So what skill sets do we have in our training that makes it easy for us to become valuable assets in this process? My approach. So what are some kind of key landmarks for me and pivotal things that I kind of revisit and make sure I always fall back on it when I'm approaching patients in different situations. I'll share some cases, which some of them you guys have maybe seen, but I'll kind of share some ones that were early on and that were part of my learning process. And so I thought it'd be valuable to show what did I do 5 years ago that I thought now reflecting on like I could have done differently. And so kind of point out my own, I don't want to say mistakes, but learning moments as I've improved and gotten more confident and better at doing this. And then credit for just a little bit of credit is due to so many people have been a part of my process to getting to this point. And so I can't be where I am without the kind of the people around me and the people who are here along the way to help kind of drive me forward. So I'm a product of many other people. So yeah. So who am I? We kind of, Renata kind of touched on it. I'm a board certified pediatric dentist. I did a GPR residency, which is a 1-year general dentistry residency that was hospital based, and it was almost like a 1-year oral surgery residency. So that gave me kind of a lot of insight into the surgical space. So much so that I almost went into oral surgery, and I was kind of conflicted between this is like confession moment, but I was conflicted to the last moment between oral surgery and pediatric dentistry, like till 10 minutes before I had to make a decision in an online portal. It was that close. So, um, full mouth, I do a fair number of cases from around the region, which are kids who might have full mouth needs, meaning teeth and different other things, and frenectomies involved as well. But when they have a full mouth of needs and they might be too young to tolerate it in their office, or they have special healthcare needs and they need to be in a more supported setting like a hospital or a surgery center, I do that on a regular basis. I have laser certification, I think that was about 5 years ago. Um, I've done the Autumn Hennings course, the TOTS training course. I've partaken in Dr. Baxter's Tongue Tied Academy course I completed. I did the Breathe Institute's baby course. There's just been like a lot of courses along the way before I thought, okay, I think I need to just kind of take part in the process now. I think I've got a good foundation, and now I feel comfortable doing it. And there's some other courses and providers that I'll talk about in the credits that also had some great courses. And so, yeah, this is like kind of my home base. So it might, if I do some weird things in this presentation, this might explain what what my behavior has come from. And so I've got 3 daughters, and that's my wife down there. So I got a 2, 4, and 6 year old. And 2 of them, I don't have their photos in my cases, but the middle one and the youngest one both were like 2 of my first releases that I did. And so I had the advantage of, I feel like my kids owed me being experiments for me to be kickstart this process. So it was kind of returning the favor, but it was a good way for me to see how much these things can impact everything, like kind of lifestyle and early parenting and sleep and so many factors. And so it gave me a lot of perspective when I'm talking to my own patients and seeing what they're going through. So yeah, that's the chaos group right there, those 3. This is kind of what my day in the life of my work looks like. On the left is a little therapy dog that we have in our practice, and so his name is Zen. So Zen's got his own schedule in our office. He's a 1-year-old puppy, but I'm just kind of showing him as a means of that we kind of will do whatever it takes to try to get kids to have a positive experience. So if we got to bring a puppy, we'll bring a puppy. If we got to dress up like Mario Kart characters and be Mario and Luigi, we're gonna dress up like Mario Kart characters. And so that's my office team on the right side from this past Halloween, and our orthodontist is Luigi, and I'm Mario there with the mustache too. And so we try to have fun, and I think just trying to do whatever it takes to keep it positive and really make it a welcoming environment. So I think besides procedures, the experience outside the procedure is a really big thing that I value, and I think that really impacts how everyone reflects on their experience and where they came and what the process was like. And so just showing you that I'm willing to get a little weird and kind of funky out there. So
This is so cool. I do have to say, I love the puppy. Whose puppy is it?
he's my puppy that we got like kind of during this COVID time. So
Ah,
we didn't know we were gonna make him a therapy puppy, but we got him and he was like 2 months old, and he was so like relaxed and calm that my wife, who's a clinical psychologist, took him to work a few days, and because we didn't know what we were going to do with him during the day,
yeah.
and she was like, "Patients kind of love him," and I thought, "Okay, let me take him to work and see what happens." And he became really popular, and so much so that people were requesting him like all over the schedule. Like they didn't want to come unless
Wow.
he was going to be there. So he has set days in the office now on this calendar.
That
Every
is so funny.
So every Tuesday he's definitely there. So if people want to like guaranteed get to have Zen during the visit, they book on a Tuesday, or they can special request him on another day. And he'll sit with kids who are really anxious and don't want to get in the chair at first. We'll just let them hang out with him for a few minutes and kind of play with him, and then they'll kind of fall asleep on their lap. And usually
Wow.
somehow that breaks the ice and lets them kind of let me in and do what we need to do.
I
So
I will say that every dental office should have a dog. I know a lot of people are like, "Oh my gosh," but
totally
oh my goodness,
game
it
changer.
changes everything.
He had like 12 patients today. He had as many patients as I did with him as I did without him, meaning 12 people that were requested him. for the day, and then
Wow.
they came in for him for his appointment time. So
Wow. And I do recommend everybody going back on his Instagram and looking at the reel or the video that you guys did for Halloween. You guys all look really good, but I'm so sorry the banana
the
took.
banana was my favorite. Banana peel was my favorite. So I was
Oh my gosh, I loved it. I couldn't stop laughing when I saw that video. All right, let's see.
so yeah. So how I started and kind of some ideas for how you can start. So for me, I thought, education is kind of the foundation of this process. And so I kind of ventured out and just thought, I'm going to take courses that are related to not only lasers, but also frenectomies, even on the myofunctional therapy side, getting in some courses and just to kind of like open my mind to allow me to kind of take in more information to then really like hone in on what is my role in this process. So I think for anybody, I'm not doing a CE course here. There's so many good speakers and people that have spoken on here, and I think getting into some of their CE courses is a great way to kind of break the ice. And some of the conferences, ALDS has good conferences, AOMT, all these airway conferences are awesome. So those are good ways to kind of get a foundation. The second would be trying to find a mentor. I think is really helpful, and so I put challenges finding a mentor because for myself, I took a bunch of courses, and then someone kind of recommended a mentor who was very close to where I practice, and it was kind of like a stumbling block because I tried to connect with this mentor, but it was clearly like a conflict of interest, and so I was almost denied the mentorship early on, and so I thought, okay, I'm going to probably have to reach farther and put a little more effort into this, and so what I did is tried to find some people that where I felt like either were farther away or were in a slightly different space, and just try to find someone who's willing to kind of share the knowledge and their experience and not encroach on their space. But it helps a lot if you're unsure about taking that first step and plunge to have someone who will let you in their office or show you what they do day to day. And some of the courses now with virtual, honestly, they're so in depth, honestly, more than they were in person, because they're sharing everything. Like they're sharing their paperwork, their office flow, their staff verbiage, and so mentorship is good. And after you get a mentor, you should continue taking more CE courses because this is a constantly evolving space. And from 6.5 years ago, 7 years ago, when I probably took my first course in it, till now, it's like every year there's something else that has like kind of grown the space more, and there's more research coming out to help really justify and show that some of the things you're seeing really do have some truth to them, and it's not just anecdotal evidence. We're getting some good longitudinal data, and so that really helps keep pushing the envelope a little bit. Case selection. So that I had an advantage. I had two kids, so my case selection was a little easy, and they couldn't really say no. I was able to sign the consent and do the procedure for them, so uh, that was easy. But case selection, I say that there's some of the cases are way more complex. If you're getting older patients who have way more compensations going on, there's obviously more players involved and more pieces, and so I think starting small, learning from a more simple experience, and kind of growing from there as your confidence builds and your knowledge level builds. So those are kind of good foundations that I would recommend for people to kind of get confidence to grow into this space.
And I do have to say, for you guys, I was just reviewing our lineup for next year with Airway Circle and talking about this continuing education hours and courses. It is going to be insane. I cannot wait for you guys to see the amount of content and from all different areas in the airway field. Everybody's going to have a little bit of something they're going to be able to benefit from. And all of these courses do give 4 continuing education hours. So we have one of them a month. And I call them the master classes. So stay tuned.
How to grow. So after kind of those foundations, I think once you've gained confidence and knowledge and you start to feel comfortable, I think the next thing is you do need to network, and the airway circle is like the ultimate networking avenue, but things like this, CE courses are great. You can meet other providers from different parts of the country or even world, and so those are great ways to share knowledge and share cases, and just kind of give you some confidence boost. The virtual I put on there because it's kind of seemed like a disaster early on, but it's kind of like we found a little silver lining in it. And this setting right now is the silver lining, is that people can access this from everywhere, and we can have hundreds of people in one setting sharing a lot of knowledge. So it's the difficulty of travel and organizing your life and your practice or your work to get educated, which has always been a challenge, is kind of on the back seat now. You can really find your own time and find ways to get educated and watch pre-recorded meetings. You can do so many things. So office visits. So I was like a Christmas caroler, like going door to door almost early on. When I felt comfortable enough, I was like, you know what? There's kind of like a very few number of people that were really established in this area, but there's a lot of need, including my own patients that I was seeing that were not going to be seeing these other providers. And so what I had to do was really do whatever it took to get providers to sit down and have a conversation with me, and me kind of show that I'm prepared to be like a valuable asset in this. And so part of that is just being, I think, really honest, like knowing, I put on there, knowing your limitations. So that means like, don't take on a case you're not comfortable taking on, or a case that can't be treated in the setting that you're capable of treating in. And so you can give insight, but knowing that, this, I see this case, maybe someone gives you a referral, but also knowing, hey, this is a case that I think is beyond my scope for now. I want to learn and be a part of this process, but I know in the best interest of the patient that there's another provider, whether it's ENT, an oral surgeon, whatever it may be, that can provide better care at this moment. And so I think within this kind of group team approach, your other team members, I've realized, will appreciate more just doing what is right for the patient. And so social media I put on there, some of you guys will start maybe seeing some of the stuff I post on social media, but social media was a great way to connect with people that you might have never met also. And so for me, it was worth putting cases that I do. And so I think that there was like a kind of big decision for me to say, how much disclosure do I want to show about what I'm doing and how much I'm learning? And that was like a big thing to say, I'm going to show my cases and the progress, and there could be critiques. There's always is, right? But I also was like, this kind of shows that I'm willing to show you what I'm capable of. And if you have critiques, great, let me know. I'm open to learning. I have no gripes about it. This is a big process, and I've come a long way in this 6 years or so. And so I think just being open, it takes a little bit of humility, but it's worth it. I think it's what has got me here to get talk to you guys. So why a pediatric dentist? And I know there's been other pediatric dentists on here, but I think it's good to know what are some of our foundations in our training that make it kind of maybe an easier, not always super easy, but an easier transition to get more into this airway space and be a release provider. So our training in terms of residency starts from pretty much birth and into adult age, depending on what their healthcare needs are. If there's patients with disabilities or special needs, we're seeing them into even late adulthood. We're trained in different forms of sedation, and so we're trained to do oral sedation, we do general anesthesia, work with anesthesiologists, all different levels of sedation, which if we can avoid sedating patients, we do, but I think a big part of it is that we have that capability in situations where a patient absolutely needs care and they need some means of doing it. Behavior management, that's probably one of the biggest ones. I would say a lot of times if I'm seeing a patient now, even we see patients from general dentists or even who's have an initial evaluation with an ENT or some other provider who provides surgical services. And a big factor is, can they get a patient to tolerate this treatment in their office setting? And a majority, it's really challenging when they see it, when there's a 1-year-old or a 2-year-old who's seemingly not able to cooperate and stay open and follow instructions. But like our baseline is uncooperative, kind of an inability to cooperate. We are just like honed into being able to find opportunities to get kids to at least tolerate treatment and cooperate for just enough time for us to work fast and get what we need done. So we get trained in a lot of sedation, but I think as pediatric dentists, as we come out and practice and we get experience, our behavior management skills start to override our sedation capabilities. And so that's happened for myself. It's rare that I'm sedating a patient unless there is, an entire mouthful of work needed. It's almost never happening. It's really behavior management. That might involve a dog or a costume, but it really involves whatever it takes and kind of molding yourself to the needs of the patient and family to make things work. So sometimes it's timing, just knowing that it's not the right time for that patient and in the process. Working with parents, so we're already, the parent, child, dyad, and the provider is a huge part of it, right? We don't make our pitch to the 2-year-old. We're talking about a 2-year-old with a parent and their kind of how it impacts both of them. And so that's another foundational piece that we're doing from day one in residency and getting trained to do is kind of working with parents to the needs of the family. And then being in the mouth early. So we do see patients and we are physically in there with our hands. And so pediatricians are seeing patients from birth, absolutely, but putting fingers and hands in the mouth and laying them back and visually looking in the airway is not necessarily a foundational piece. We are like, our scope of practice starts in this small circle of space in their mouth. And so we're used to having to lay them back, look in their mouth, physically feeling things like typically teeth initially, but obviously as you can get educated in this space, it's a pretty easy transition to start to get comfortable with the soft tissue and other things in the mouth. So we are seeing things early. It's really like a missed opportunity to provide the best for your patients to not get more educated on this because they are seeing us twice a year, generally, no matter what. And so this is a great way to find opportunities to help the patient beyond the dental realm. And so that if you start doing it and you get in this space, you'll see families and parents and how they respond to some of the ways you can impact their life that you'll see are way more rewarding than a filling on a tooth, which is pretty amazing. So what's my approach? My kind of starting point, and I think a lot of the practices is having some kind of questionnaire as a basic part of the practice. And the questionnaire is not to say we want to find issues and we want to find that they have some kind of restrictions or tethered oral tissues. It's to say we really are evaluating this patient for things beyond just baby teeth for a pediatric dentist, for example. And so the questionnaire, there's a lot of good ones out there from some of the courses, but ours is just asking a lot about their breathing, their speech, their feeding, their kind of birth process and schooling. And so what that does is it kind of there might be things the parents have never thought about, but they might be finding some symptoms or things that are going on in their day-to-day life that they a lot of times will think these are kind of weird questions for the pediatric dentist to be asking me I didn't anticipate asking here. But they break the ice and open the conversation about other things that you're likely to find once you look in the mouth. And so when you do look in the mouth and you see some things that look like they probably can benefit from seeing in another provider, it makes it a lot easier to have that conversation to say, I noticed on the questionnaire, there's some things in the history here. Let's kind of revisit those. There's snoring, just as an example, snoring, picky eating, whatever it may be, mouth breathing, tongue thrusting, drooling. So many things that they are not thinking are like they're kind of thinking this is a tooth related visit, but these are things that open the door to a lot of other things. Avoiding general anesthesia. So I do see patients under general anesthesia with an anesthesiologist occasionally, but I really do everything I can to avoid it. It is the absolute last line for me. Medicine has come a long way and you can put someone under anesthesia and wake them up 15 minutes later. However, for myself, I really try to be as conservative as possible, and having someone's breathing supported by a machine is just not ideal no matter what. And so if I can minimize that, I'm doing whatever it takes to minimize that. And so I've actually never done it for just a release at this point. there's been, I think, one patient who I've had worked with another provider who did it, and it was special circumstances. But for my own patients, I've never done it and that be the only thing that was done while under anesthesia, meaning just a 90 seconds of doing a release. That kind of cost the pros and cons of that, the risk of potentially having an adverse reaction under general anesthesia. I'm always thinking there's got to be another way to make this work. So again, dogs, Halloween costumes, whatever it might be, timing, some more therapy, getting him into the right space to do it. Treating the patient, not the problem. So people are going to come in and say, I've noticed this one thing, and this is what we're here to ask questions about. And you can get really kind of tunnel vision of honing into that one symptom or one issue that they're talking about. But you really got to look at the patient as a whole. And so that means, what are their life circumstances, their capabilities? It might even be kind of getting a sense of their financial abilities to go through this process and find providers that are going to work with them through it. And so always kind of taking a step back and thinking, we know this flow chart of, you see a patient, they have this, you kind of follow the flow chart. This is kind of how medicine and dentistry teaches us, is if they have symptom A, you follow the flow chart down the right side of the page. If they have symptom B, you follow the flow chart down the left side of the page. However, that's not the reality of life. There's always outliers and other circumstances. And so you really have to think, even if the ideal is, if A is happening, they should go to step B, this patient might not be capable of going to step B. You might have to go to C or D, or take a step back and wait and take a different avenue. And so just kind of always remembering that when patients can't follow things as ideal as you'd like them to. Putting value in the process. And so that means kind of talking patients through and having the time and allowing the time for patients to understand that this is not a quick visit, eval, you do something for them and their life has changed. Because if you go on social media enough, that is what you may believe at times. If you read enough blogs and forums, there is a kind of like, it's easy to fall into the trap that I showed up, they noticed this, something was done, and our life has changed. It may have in the short moment, but really big picture, you want to get the best benefit for them. And so part of that is, you do need to have time allocated to be able to speak to people, hear what their concerns are, and put value in the process. Meaning, if you need them to see another provider, whether it's a lactation consultant, a speech therapist, whatever it may be, you need the time to make them understand why do they need to do that? And why can't you just give them an easy solution in the moment? So that usually comes with a lot of questions, sometimes a little pushback, but if you've done enough educating in yourself, you will believe it enough to know that you really need them to do this like the right way. And then the last one was educating your team and kind of having them be believers in the process. So all these practices, the dental practices, ENTs, everything it's from the front desk all the way back to the doctor. And so part of that is, you should want your team to be educated on the things that you're talking to your patients about. And so if they're there and they're not really understanding what you're saying to patients, and you leave the room and they ask staff member a question, or you can just kind of feel the energy in the air and of your team when it's not truly kind of like a team feeling, believing in the process. So I think taking the time to educate your team is a good way to practice for yourself, to see, do you feel knowledgeable enough in this process? Meaning, it's easy to say I took the course, but if someone says, can you teach someone else? That's different. Yeah. So some cases. Yeah, that's it. That's good. So some cases. So these are kind of starting back in generally somewhat sequential order, but starting as old as 2016, I think was probably some of the early ones that I found. I think this was probably 2016. So this was a maxillary frenum that was released. I think the patient actually had some restorative work done on the front teeth there. So there's some material on those front teeth because they had a difficult time brushing. Clearly pretty restrictive maxillary frenum. You can see a lot of kind of tension and blanching of the tissue down in between. And then you can see how much more full the lip looks post-release. I put this one as a good critiquing for myself, because I look at this and I say, what could have been done differently here? If I would have done this now. I think part of this, if I look at it now, I probably released, and this is kind of specifics on the release, almost starting in the middle of that frenum while holding it up, as opposed to really releasing from the base of the frenum, meaning starting where the attachment is all the way at the bottom. Yeah, I probably started almost in the middle of that, not really a diamond. That looks like a pear. So that's my critique on that is I started probably high. It did open up a little bit, but then I had to go down to the bottom and start to kind of remove some of that excess tissue. And even then, I still feel like on the sides of that, there's still some tension laterally, and there's definitely some connective tissue. Most of that white inside the opened area is still some connective tissue there. And so typically when I'm releasing now, I'm at least making sure there's not fibers and some fascia that's kind of running up and down there. And I should really get to down to the mucosa, meaning either muscle, like stopping right where muscle starts, but at least making sure there's not bands of connective tissue. Like I can see there some vertical bands of connective tissue where they still benefited, but like it definitely could have been done better, in my mind in that one. So another one. This is another early one. So on this one's a tongue. Definitely still big benefit of how easily I'm getting kind of the base of the tongue to lift up. However, and better diamond shape a little bit, which is kind of a good guide. Again, when I look into that opening, I think other than the kind of 2 to 3 millimeters right there in the middle of where I did the release, laterally, there's still a fair amount of fascia laying there. So you can see that little film of white connective tissue laying there that I would have liked to release and got a more like cleaner field there. And so that probably would have allowed an even easier lifting of the tissue and elevation there. So these are all ones that I are learning moments. So um, this one's not too bad. Just looks a little more crazy a little bit, like at the top part of it. Sometimes you're going to get a little bit of bleeding. It looks a little unclear, kind of where I ended on the release up there. Um, I think I came down pretty good. Sometimes you see that hump of tissue, that kind of curve at the bottom, and a lot of times people think that's just like the papilla, meaning like normal tissue in between the teeth. But it's really when you see that much blanching at the bottom, that's most likely the frenum is wrapping around to the palate. And so that's like the tissue balling up, wrapping all the way to the palate. So if you release just on the front end, you'll get improvement in the lip position, but a lot of times you won't get the diastema to close as easily because that little ball of tissue will still stay there and kind of prevent closure. This one was pretty cool. This was probably like the best early one that I did because this patient I remember very, very distinctly. These were twins actually, and hers they had never really seen her teeth like when she smiled. You would never see the teeth, and you can see how thick that lip tissue is coming down in between there. And even then, when I lifted, there's a little start of a cavity right in between the two front teeth a little bit there. And so they were when I pointed that out, they said, "Well, we can't even see her teeth in general, like let alone get in there and brush that area. That's almost impossible." And so that picture at the bottom, so kind of a big diamond, now just kind of critiquing in the upper right picture, probably went a little far laterally to the left in that photo. I could have probably stopped a little short of that. And then the bottom picture is 7 days post-op, which is amazing. 7 days. And when they came in, they said it is like different child in terms of like when they take pictures. You can see almost all their front teeth, canine to canine. And then when we saw them, about 3 months after this, that diastema was almost completely closed there. So 7 days, the healing is like incredible. Sometimes, a lot of the research is 6 or 7 days up to sometimes 20 days of healing. This kid is clearly like a super healer here, pretty quick healer. And so the key in this one is that they're really doing the post-op stretches and valuing that because the healing is happening really quickly. And so if they don't value that the need to do that and wound healing exercises, you're going to get some quick reattachment, and then it's really hard if they're not coming in and seeing another provider to help do those stretches. So you can go down the rough path. So this was amazing. 7 days. I thought like you wouldn't even know, probably wouldn't know she had a phonectomy done at that point. This is a baby. These ones are the baby ones that you'll see are probably about 2 weeks old or less for the most part. I feel like most of them seeing are in the first 2 weeks. This one was pretty good release, I think. You get a good diamond there so that, you know, you're kind of entering just above some of those salivary ducts at the bottom of that frenum, but you're kind of just making sure you're putting a lot of tension so that as you're releasing, you're truly getting to see how much elevation of the tongue is happening and how much elevation are you getting without the floor of the mouth kind of compensating and coming up with it. So I'm pushing pretty hard there to get a little bit of lift, but in the bottom one, I'm not pushing that much, and I'm easily able to get that open. So that's an immediate post-op. Maybe a little fascia in there that I could release more, but pretty good lift, and had some pretty great feeding improvement and waking. And typically I feel like it's about 5 days after they're kind of out of the rough patch, and they start to really see improvement kicking in, especially on the early ones. This one was pretty wild because the tension was so much so that it clearly was impacting how the bone was coming down and the teeth were coming down. There is like a noticeable step in the dental alignment, and this is probably a 3-year-old. And so huge diastema, maybe 4 millimeters there, up to 5. Um, for pediatric dentistry, a lot of what we're taught is that you can get some natural closure of a diastema, not really relating to a frenum, but just as a diastema kind of rule of thumb is you can get 2 to 3 millimeters of natural closure when the adult teeth come in. This is definitely more than that. And even if it was less, the thickness of that tissue and how much of an impact it's causing on the bone there is like just wild. That was probably the biggest bone defect that I saw in the tension there. And so same thing, this one, probably half of that space closed within 3 months. So it also looked like a different child. I mean, this one smiling looks like they've lost a tooth at this point, but they clearly haven't. So this one's pretty cool. So these are kind of good ones to see because at this age, these patients have been through the process. So they have really gone through the therapy. They've been doing exercises. They've been preparing for a release at this point. And so that's me kind of gentle but firm elevation there, trying to lift the tongue. And I'm not getting too much, he's not fully open there. He's maybe getting about halfway to the palate. And then I'm not lifting at all. And this is immediate post-op. His tongue has kind of been somewhat reprogrammed from doing some of the myofunctional therapy and preparing itself to really get to that spot. And he's definitely over 80% of the way there, kind of touching the spot there. So now this continues. He still needs to do work on the back end of this, but pretty awesome immediate improvement. And a lot of times they will kind of sit up and, they're numb a little bit in the area, but beyond the tongue that they'll notice is that they will feel like kind of a change in their body, like they almost feel strange, like loopy, like this weird relaxation of feeling. So it's kind of cool when they sit up and they're like, I don't know about my tongue, but I do feel a little different, so it's pretty cool to see that.
I do have to comment for all my orofacial myofunctional therapists watching right now. We all can tell that this tongue had myofunctional therapy before.
Right? It's
If
amazing.
they look like that right after the release, you can tell just by looking at it how they have worked on tongue posture, strength, tone. It's insane the difference.
Yeah, it's amazing. I mean, look, just the floor of the mouth, and you're right, tongue posture. So these are where I was valuing the process more and really kind of not compromising the big picture for the short term result. And so it's really cool to see how much they progress so quickly afterwards when they've done the steps on the front end.
Beautiful.
Look at this is another one. I mean, this one is I'm pretty much the only reason that tongue is lifting up at that point is me pulling it up. That you can even tell that like the tip of their tongue is not making any effort to truly elevate itself in that first photo. The one below it is immediate post-op, and the one to the right is 3 weeks post-op. So and the scab, the kind of scar diamond there is gone. And that patient, I mean, you can barely see the floor of the mouth elevating there. I probably could have had them do like kind of a suction to see how much of the posterior segment is elevating, but still the amount of lift on their tongue was like pretty incredible at that age. And so this one, I believe, is like a 7 or 8-year-old at this point. But pretty awesome result there, which was exciting. And again, you can't really tell they had a frenectomy done. Like you're looking at the tissue, and it's
Insane. What are you doing to these people?
yeah.
This tissue
um,
is insane.
this one is like a 12 to, I think they were like in the 12 to 18-month range. This one was definitely having some, you can't see in the top. Let me see if the top photo shows it. No, it doesn't. But this one had like chronic lip blisters, still nursing. They were hoping to nurse until kind of 2 to 3, having challenges flanging the upper lip out. Not really much of a diastema, but clearly some tension there and having some challenges of getting a good seal just based on symptoms. I know this is kind of recurring theme in all the speakers is like functional impact is obviously kind of the key indicator of is the patient that really truly would benefit from release. So is there actual functional impairment to justify doing some kind of surgical intervention? And so in this case, we kind of reviewed all the options and what symptoms they had, and to us and them, it was worth it. And so that picture is like 5 days post-op. So pretty good there, pretty good healing, also happening pretty quickly. And you can see there's no more blanching at the bottom, so that's a good sign that there's not much tension happening when lifting the lip there.
Mm.
Another baby, so these are immediate post-op. That one on the bottom right is a little blurry, but in these, you can see some notching in the first one. So not only blanching where the frenum's attaching at the bottom, but a little notch there. So you're getting some tension, enough so that it's causing some impairment of bone levels there. And then these were feeding difficulties for sure. So if there's a tongue tie, you know, a lot of providers have already kind of talked about. There's high likelihood that if there's a lip tie, that there's tongue tie, but if there's a tongue tie, not necessarily a lip tie. So in this one, the symptoms and all things kind of pointed to it's worth releasing the tongue and seeing the benefit. And there was definitely significant feeding changes that occurred in the coming weeks. This is another good one. So that one's pretty thick tissue. This is immediate post-op also. You know, when you look at the tongue one, the lip one's obviously a little more noticeable on the tongue. Still pretty good blanching, and a lot of these, not just the anterior portion, but the anterior what seems noticeable, but it's when you're getting in there, you realize it, you know, after you release 2 or 3 millimeters in the front, there's a lot of times like another 3 to 4 millimeters posteriorly that's getting missed. And so some of these have had, you know, what they call the tongue tie clipped as newborns, but they continue to have issues, and they've come in and it's pretty clear that they didn't go far enough back posteriorly. And that's not to blame. They still sometimes had improvement before leaving the hospital, but it's hard with only scissors at this age to get and kind of reach back and get every fiber as far as you can posteriorly without worrying about hitting some kind of vital structure. And so I always make sure that if they feel like there's resentment about what they already did before leaving the hospital, that kind of like the theme of this thing is that you don't know what you don't know, but they know that that person in the hospital knew that if they can at least release some of it, even anteriorly, while this patient goes home at 2 days of age, there may be some benefit. Doesn't mean they might not need to see another provider, but they're doing what they know and they can at that moment. So try not to let them kind of dwell on the past and where they've been before, because it can sometimes hold you back from being open to progressing forward. So,
I have a
in,
question.
yeah,
I always have lots of questions, but the second picture, this picture of, I don't know if you can see my mouse.
yep.
Is this, has the tongue been released here also?
The tongue has, yes. That's a good question.
Did you take photos after you released both?
I think both. I want to say it's both.
And I'm asking that because you can really see a difference of how flat the tongue is here,
Yeah.
and immediately the sides are already up.
Yeah. It
Like
would be post. It would be post. We wouldn't
it
stop after one and then take the photo. So
It
yes, you're
looks
right.
to me like it's released. And I have another question that a lot of people have been asking. On an older child or adult, do you ever release the bottom of the Eiffel Tower?
So I have on rare occasion. And the only reason I've done that, not necessarily right near the gland there, but where the attachment has been on the lingual of the anterior teeth down there, especially if I see like some recession gingivally. Typically, this has come with time, obviously. If I'm putting enough tension while holding the tongue up and I do release like in the appropriate place posteriorly, that really should, the lower part should kind of sink back into the floor of the mouth. So while it looks like, oh, there's this gland and there's two areas causing tension, it really is the superior portion right above that, that the tension is happening, and the top, everything above it should kind of pull back into the tongue, and everything below it should kind of separate into the floor of the mouth. So if I go far back enough and keep tension while doing it, it's pretty rare that I need to do it. Meaning you'll notice that you can lift way further back and you won't see, it's almost hard to replicate that Eiffel Tower because there's nothing down there anymore. That gland has settled down into the floor of the mouth.
Wow. Fantastic.
And this is a pre, immediate post, and 7-day. And so this is a cool one. I kind of wanted to just show one that shows what type of wound and healing do you want to see at 7 days. Especially the tongue was a great one. The lip is kind of healing fast there, so they've almost passed that kind of white scab phase. They're on the back end of that. But on the tongue, which typically does take longer, this was a good way for me to see, are they really getting lifts and doing a good job to really prevent reattachment? And that one is like, they almost have the entire area still open. Like the whole diamond is almost still open there, all around. Exactly. And so when I see them at day 7, I always go in and I tell them they're not going to love it probably, but I know how much kind of force is required and the feeling that's needed to make sure I'm getting a good lift posteriorly. And so while I trust the parent or whoever's involved in the process, it's an opportunity for me to say, if there's some reattachment, sometimes I can manually kind of help get them back on course and kickstart them being back to where they need to be. So in this one, I was just so impressed that the parent had done such a good job that I said, I got to take a picture so I can show you how I know you're getting such a good lift back there. And so you can really appreciate the whole diamond there. And I can't remember if it's this one or another newborn, but there's one, it might be this one, who had kind of the big change that they noticed is that they were already doing kind of working with PT and doing a lot of tummy time. And I know, tummy time is a big part of, is such a beneficial thing in this process. And so they were 4-month-old, 3.5-month-old, and they were getting about 5 minutes of tummy time before the child was like exhausted, heads on the ground, and this, they needed a significant break. And she came at day 7, and the physical therapist said that, I don't think you need to come anymore. And they did 15 minutes at day 7, and they had taken the first 3 months to get to 5 minutes. And so she said it was kind of like amazing that he's not only doing 15 minutes, he's just so much more active and mobile and less kind of fussy while in tummy land. He wanted to stay there as opposed to it being kind of like a squirming on their tummy, fighting this kind of tension, forward head posture tension, big head, small body, and that all the tension is pulling it down, and they're trying to build neck strength, but really neck strength is also adding some impact to their back, hips, lower back, so many things, instead of just giving them full functional movement at that point.
And look at the tension, guys, before the release. The tension of this upper lip and the tension of the lower lip.
Yeah.
And then it's gone. Look how relaxed. It's crazy.
Awesome. Another one, another 2-week-old. Some of these have been probably in the last 2 months. This one, so the top right picture is kind of a good where I started to realize, okay, I need that band of tissue at the bottom is really wrapping posteriorly, and the follow-ups helped me kind of notice that, where yes, the lips would look more relaxed, but I would still see some kind of hump of tissue there, and when teeth would come in, there might still be a diastema there, even though the frenum is not coming down and attaching visibly. And then the tongue, this was just to kind of see what am I looking for, and in this one, what I would say is the positive is I almost see no fascia in there in that diamond at that point. So there's no fibers attaching kind of top to bottom, holding tension there. And I'm able to get a pretty good lift and get a good photo kind of to capture that. So this is immediate post-op for both of these. This is a cool one. So this one was a child who was in and out of therapy for years. And some of the main things that they were having challenges was a lot of lip posture and movement. And so very difficult time doing any kind of exercises where they had to get some separation of lips from their dental arch or teeth. So, kind of exercises where they're ballooning their mouth, all those were extremely difficult. Just like a lot of tension in the cheek muscles, head, neck area. And so they had already done an evaluation. I was not their regular provider as a dentist, but the therapist, I mean, speech therapist referred and said, I'm seeing restrictions all over the place. And this is the most like outlier one that I've done because this is the first set of pictures of this child. You will see buccal ties for the same child that were all over the place, causing some periodontal impact, meaning those teeth that are not dropping in there had some significant restrictions that you capture better. So this one had huge changes in eating. This is a older child. This is like I don't want to say 11 or 12. Very picky eating, mostly soft foods, pretty quiet, pretty challenging to keep good oral hygiene because they didn't like the feeling of the toothbrush kind of pressing between their cheek and the gum line. And so the buccal ties on the next slide are just like, it's just so many restrictions. So this is what they originally referred for, is that they saw like on the upper left photo all the way, you almost see two buccal ties coming from the cheek there at that point. And so all four quadrants had some ties, some more than others, but they were like at a point where they've done therapy for so long, they said they want anything that's going to give them a chance at this point to get some improvement. And so the right side is the release of those buccal ties. And it was a big difference in some of the therapy and exercises they were able to proceed with afterwards. And then about a month after, just basic oral hygiene and willingness to explore and try some other foods was way more. They were willing to try things even in their therapy and feeding therapy to kind of explore new things, and all of that impacts so many things: their diet, their overall health, so many factors. So this was just like a wild one that I thought would be cool to show just how much there can be restrictions, not just kind of in the central plane that we kind of get fixated on at that point.
Wow.
Another tongue one. This one is probably similarly about a 10 or 11-year old. This one, just on the initial part, I kind of tried to show how much like white fascia and connective tissue you see under the tongue, and it's not even very pink under the tongue at that point. So this one was like a lot of tissue posteriorly. As I got further back, it felt like I was going forever. I kept going. I do a little lift. Sometimes it'll take, where I think, "Oh, I'm getting pretty good tension relief." I'll manually lift. I'll still see some, kind of the floor of the mouth elevating, even looking at under their chin to see if I'm seeing some elevation there. And then sometimes their amount of opening, I'll notice like I still feel like I'm holding them open to only a certain amount, and there's resistance beyond that, and their maximum opening is not that significant yet. And when I release enough, I will get there kind of a breaking point where suddenly they will go and just kind of relax, almost like their mouth will pop open more, like another centimeter. And it's like this release of tension that happens at that point. So this one, just kind of showing how far back I had to go. It's hard to appreciate the depth, but um, how far back I had to go to release it. So another one, this was, I think the lingual one was just a good one to see that I'm basically removed as much of that tissue as I could, to get to where the start of the muscle was. Sometimes when you're getting really close, this is just Dr. Baxter kind of does this, which is a good little insight, is if you feel like you're getting close to vital structures, it doesn't necessarily have to be that like a scalpel or scissors or a laser is the only tool that you can use at that point. Meaning it's getting really thin. You might be getting close to a vein. You can sometimes use like a cotton tip applicator or something else to get into that space and just kind of break some of those small fibers at that point. So sometimes I'm releasing a majority of it, but laterally there's more vital structures there. So that's an area you got to be a little careful. There's a it's called a lingual vein that runs there. And so on the lateral, sometimes if I still feel like I'm getting some elevation in the middle, but like the full base of the tongue is not elevating, I can take something blunt like a sterile cotton applicator and kind of go into the lateral portions and get some release of those tissues and elevation. So these are things that like slowly I've noticed over time, like how can I get a little more release of that tension and it not always be just kind of go guns blazing in there and cutting tissue. These are, especially for babies, it's you got to be pretty careful of some of those vital structures. This is one like 2 weeks ago, and so this this is the dad, and the next page you'll see his daughter. Um, we have also work in a orthodontic and pediatric practice, so we have both in our practice, and so they were orthodontic patients who came in, and it was mom and daughter. And upon leaving from their orthodontic visit, they said, we're coming in for our daughter who has a low frenum to get released. How would you feel about if I brought my husband and you did it for him too? I've never met him before. And I said, sure, bring him and we'll at least look at it and see. And she said, well, I think my daughter's only going to do it if he does it. So that's kind of our plan to make it work. However, that was not just, in hindsight, I think they were more trusting that the attachment would work in that sense, but it was kind of mixed bag results. So he went first, and I usually were not having many people watching, but they were very adamant that they wanted their daughter to see that it was pretty easy. I was from the beginning thought, I don't know if she's going to think this is easy or if she's going to think this doesn't look that fun, And of course, as I said, she was like, I'm not sure I want to do this now after he did it. But this was the dad, and this is a 5-day post-op. So what his was interesting was that he has a small diastema. He's already finished orthodontics years ago. If he's supposed to wear a retainer, typically 2 to 3 days a week, he's supposed to sleep with his retainer in. If he doesn't wear it 2 days in a row, the diastema opens. If he wears it every day, the diastema is completely closed. And so for him, the goal was he wants to see, and this is other than being a good example for his daughter, was let's see if he can do this. Things settle, the tooth kind of settle. Actually, in the 5-day photo, they are a little closer together, actually. But realistically, a few weeks out, I told him I'd be curious to see if you really go back to wearing your retainer only 2 to 3 days a week, are you going to minimize that opening that happens? And that's something that bothered him, is that he couldn't go one night without wearing it and not have a gap forming there. So, yeah, he probably tolerated it not as well as his 7-year-old daughter, actually, so which didn't help out. I thought he was the more challenging patient. This is his daughter, 5-day follow-up, which is amazing. So she did great on the front end. Some of Dr. Kotlow's stuff, if you look at his early recommendations, I think it's Dr. Kotlow's that did it. He had recommended, and this is mixed. I've used this sometimes, but basically 2 ideal windows of a release for diastema closure. And for him, I believe it was in the 12 to 18 month range, which is when you're getting your baby canines, or in the 6 to 8-year-old range when your permanent teeth, this is exact timing, are partially erupted. So you're removing the tension as those teeth are erupting with the hope that they are going to erupt and come closer together without resistance there. And so on the first one, she does have that little ball of tissue in between. It's hard. I don't know how easily you can appreciate it. There's not a flat gingival line when you go from the 2 front teeth, but in the 5-day post-op, her gum tissue is completely smooth and flat. You can barely tell that she had it done at day 5, which is amazing. So I think she did better with stretches than dad did. So I thought it was a fun one to share. And this is a recent one. This is from about a week ago. So this is another patient, 12 years old, has autism, pretty much nonverbal. He's been in therapy since 2 years of age. This was a cool one to just see how much you can have an impact on things beyond just the dental realm. So they've been in therapy. They did the myofunctional. They finally have kind of reached a provider and started doing myofunctional therapy, who said, I see some oral restrictions that was never really talked about before. And so there was kind of this, fixation on the past, which was one of those ones where we had to really talk about, you've now kind of come to a provider that really might open some doors. So let's take advantage, as opposed to kind of being mad about the process. But I get it. She spent a lot of time, financial commitment, and she didn't see that much improvement in him over the years, except eating a little bit, but verbally minimal to none. So he came in, he did the release. She came, I want to say, the end of last week, and this is a 7-day post-op follow-up. And it was very emotional visit for her. She came in and said it was just wild that, he was very used to her going in the mouth. He had no problem because he had been kind of accustomed to the process from the beginning. They had already been putting hands in there, helping him do lifts. He tolerated it so well. First provider wanted to put him under general anesthesia. In this case, we did it in the office. It was like a 5-minute visit. He, for the first time, has like consciously tried to put words out, meaning actual sounds, letters, putting 2, 3 little words together and trying to make certain syllables and sounds. And to her, that was like a life-changing thing. He's 12. He's never made a clear sound except some kind of like, kind of humming and spontaneous sounds. And she's like, he's kind of saying sounds that I know what he's trying to say to me. And that's like,
Wow.
I know. She was so emotional that I was like, man, I get fixated on the process a little bit, but it was one of those where I'm just like, I feel pretty lucky, and this is where it's really rewarding and cool. She was apologetic for crying, but I thought, you're probably gonna make me cry. This is
I
pretty
know.
amazing. It's a big commitment to do that for 10 years of finding providers and people to help you, and it was almost like she had a huge sense of relief to see like he's probably going to be able to make progress now and with the therapy. And so really, really cool. I'm not lifting him there. That's him just doing it a little bit. But the immediate post-op, look at his tongue. He's like flying to the roof of his mouth, which again, like Renata said, that was a sign that he was really committed to the process from the beginning. His mom really valued it and was really preparing him for what was to come. So, even when I first saw him, I thought, general anesthesia, I don't know, let's just kind of work slow here and talk to him and give him time. I think he played with Zen actually, which is our little dog, our little therapy puppy. Um, and he just kind of warmed up, and I thought, we don't need a lot of time in his mouth. We can just like do whatever it takes to make him comfortable. And so now he did this, he didn't get put to sleep. He's having like a life impacting change. It's pretty amazing stuff. It's really, really cool. That might be the last case. Oh,
Incredible. Is
one
it
more.
the last one?
Yeah. So this is one more. This one you can see some of the connective tissue that's still the fascia that's like at the bottom of the diamond there, but still not like vertical bands connecting. You can kind of see some of the white at the top of the diamond, some of the white at the bottom. Sometimes I'll clean those out if they're not too close to the glands in the bottom part, but really just making sure there's no tension vertically, holding the base of the tongue down in the back portion of the tongue. All of these have been treated in the office. None of the ones I've shown you were patients under anesthesia. And this is kind of coming to the end part. So just some thank yous for kind of how did I get to this place? A big part of it is kind of my training and background, obviously, my residency. I went to Montefiore for my pediatric residency, which is in New York. I still think they're the best, so let's shout out to them. All the courses that I took and providers that were so open to sharing the knowledge. Mentors locally were hard to find, but people like yourself, Renata, and other people who are just kind of like, let's get people educated and get it out there, have been such a big part of the process. That's Dr. Baxter's course, Dr. Gahary, the Breathe Institute, Autumn Henning's course, Mary Francis did a course. All these people were great educators for me in the process. So again, I'm a product of them. And then the providers, people who I kind of had to really get annoying and keep reaching out to and find a way, but they've kind of finally let me in. And it's not only let me in, but they've become a big learning vessel for myself. We go back and forth and share knowledge, and they show me cases that I'm like, that's a great case, and we can kind of hash some things out. And there's so much learning. So I'm really lucky. There's a lot of great providers in this team dynamic in the DC area that I work with. Just a few I'll name: Jillian Gladstone, Hallie Bolkin, Simon Says is great, Mary Francis, Angie Lehman, Karen Ernst. Those are all good ones. And then the people virtually who I've got to meet. Yourself, Dr. Marielli is one we talked recently. Was really cool.
Love her.
Her stuff is so fun, and her fun stuff is like, man, I feel like she's kind of quirky and like me, and is willing to do what it takes to connect with people. And we had a great chat recently, which was awesome. And just some of the people in our area who are really committed to early child development. There's a lot of good um, areas for them. Pediatric Development Center is a big one nearby that sees kids for everything, OT, PT, speech, feeding, lot of support there for them. So that's a big one. And then the office team, my office team who you saw, who's really committed to making it a fun experience for kids. Everyone has really bought into the process. So I try to tell my team as much as I can every day that I'm super lucky to work with them, and I try to make it worth it and fun for them. So I'm fortunate to get to go to work and have fun. And then the patients, that's um, given me some. I saw your message. The patients, so trusting me in the process and letting me do this and really be a part of their journey. So I'm really lucky for that. That's it. I'll stop with the shout outs.
This
I
is
can keep going.
this is wonderful. My gosh. Yes, we have many questions, but we have no more time.
Oh no, I'm sorry.
No, it's totally fine. We wanted to listen to you. I think that we should schedule a different day for us to do questions only. What do you guys
Anytime.
think?
Yeah.
Yes, I have questions coming in on Facebook also. Great cases, Dr. Eric. Chris Zombeck is saying, thank you for sharing. This was wonderful.
Oh,
Thank you
thanks.
my gosh, we know how much time it takes to put, these presentations together. So we are very, very appreciative that you're taking time out of your day and out of your family to be here, sharing all this the amazing work that you're doing for your patients with all of us. So my gosh, I don't even know what to
Thanks.
say.
Well, if there's stuff, I was on the receiving end of like where I needed some help and guidance and questions answered. People can always reach out to me. I think those who I've connected with already know I'm willing to share whatever it is. People want to come by the practice. If they want to just call me or send a text or a case, I can put my contact info wherever and I have no problem. You can call my cell
Amazing. I
phone
want
or
to be respectful of people's time.
yeah,
So it's up to you guys. Should we pick just a couple?
sure.
This is a lot of great information on different cases, engaging and fun. Congratulations on your success, dedication, and humility. So nice. Look at
Thanks.
that. Oh my goodness. There's so many. Okay. Um, oh my gosh. Okay, a couple. Angela, do you refer to an orofacial myofunctional therapist pre and post frenectomy? And if so, around what age?
Yes. I mean, most of them I check with the provider. Most it's challenging before the age of 4 if they're of speaking age. A lot of them will say it's challenging depending on their maturity level. Sometimes 3-year-olds can go.
Wow. Um, and this is a question that I wrote down, Anne. What dysfunction do you look for, or dysfunctions do you look for to identify a restrictive maxillary frenum? If there's no restriction, will you leave a visible diastema?
This is all kind of what do the
From an
benefits
age.
outweigh the risk? So dysfunction could be if they're babies, it's going to be feeding, lip blisters, lack of flanging of the issue, getting an effective seal. If it's of speaking age, it's going to really be a functional evaluation with the myofunctional therapists and those doing it. So that's where, as much as I've learned about their space, I'm like trusting in the referring providers to help me do a functional assessment. I might see some things and I'll let the therapist know that, but I trust them to do a full evaluation and kind of give me the feedback of what we're seeing here.
This is a common question that patients will ask. How much does the type of laser versus scalpel or scissors matter?
There's clearly benefits that make it easier with certain tools to get good at this process, but really it's the education and provider and experience is the big thing. I've seen some ENT, Dr. Gahiri has done some with scissors and scalpel that look amazing. And that's, and he's done them with laser too, and they look amazing. Dr. Zaghi does both, combination of both. So I'm using primarily a laser. However, I've done some with scalpel and sutures also. It's just easier for it to be fast and have less risks involved if you have an appropriate laser. However, there are providers that are excellent and have years of experience and they've done it with other tools. So it's really the provider, I think, and education of them, their level.
Fantastic. Guys, we're not going to keep you guys here any longer. My gosh, I know I could stay here for one more hour listening to you. I'm sure all of us could. But let me tell you guys what's going on this week. This is our last week of Zooms and Lives of 2021. We're so excited. We had a fantastic year. Tomorrow, we have a very special meeting with Dr. Stephen Park. If you guys have not read his book, Sleep Interrupted, please do. It's amazing. If you're an Airway Circle member, we're going to be giving a book away tomorrow. So make sure that you go to our Instagram page and you share, tag two people and then share that post of Dr. Stephen Park and tag us and him on your Instagram so you can be entered to our giveaway. And then on Thursday, I'm not sure if you guys saw it, we have Dr. Sasha Gomanek. My gosh, can we end the year any better with these three amazing speakers? If you guys have any questions for them, please send it to us. We're going to try to get to them. And Dr. Eric, we're going to have to reschedule you because you're fantastic.
Oh, thank you.
And just to give you guys a shout out so you're ready for it, January 14th is our next master class. That's going to be with Dr. Dan Hansen, all about breathing. If you guys have not had the opportunity to take a course with Dr. Dan Hansen, my goodness, you're in for a good one over here. All dental professionals will get 4 hours of CEs. So stay tuned. I think that's going to go out next week. Information, if you guys can go ahead and start joining Dr. Dan Hansen's masterclass. Alrighty, guys, we are all done. Happy Tuesday, everybody. We'll see you guys tomorrow, which is not a regular day, but Wednesday at 8 p.m. Eastern Standard Time with Dr. Stephen Park. He has some amazing news for you guys. Again, you can rewatch this if you're an Airway Circle member. It's going to be on our website. It is going to go away from Facebook tonight. Anyways, thank you.
Thank you so much. Thank you, guys.
Thank you, Dr. Eric. Great to see
you
you here.
You too. We'll connect sometime for sure.
Yes, definitely.
Jennifer, thanks. You're on mute. I can't hear you.
Great job.
Thanks.
Awesome.
Thank you.
Good night, everyone.